Hello, welcome and thank you for joining us today as we continue our IB Users Group webinar series. My name is Linda Herman and I am the Client Relations Manager for Imaging Biometrics. Today's webinar is titled Considerations for Reliable and Accurate DSC MRI Acquisition and Perfusion Post-Processing. This webinar aims to provide guidance on optimizing DSC MRI acquisition perfusion post-processing technique. The goal is to ensure reliability and accuracy in clinical interpretation. It is being presented by Melissa Prah, who's an engineer 2 at the Schmeinde Lab at the Medical College of Wisconsin. We have muted the microphones and we will have a Q&A session at the end of the presentation. And the presentation is being recorded for future viewing. And now I will turn it over to Melissa.
Thank you. I have nothing to disclose. As we all know, DSC perfusion MRI, and specifically relative cerebral blood volume, has clinical value for distinguishing treatment effects from tumor, and it's associated with tumor grade and aggressiveness, in addition to progression and response. Altogether, perfusion imaging has increased confidence in both clinical decision-making and treatment monitoring. And while for a seemingly simple method, it turns out that there are many different ways to collect and to process this data. In 2020, consensus recommendations were published based on evidence-based best practices for clinical DSC MRI that were compatible with the standardized brain tumor imaging protocol that was already gaining clinical acceptance. It should also be noted that whether a moderate flip angle or a more recently identified low flip angle approach is utilized, both require post-processing leakage correction for accurate results. So, however, even with proper implementation and execution of the DSC MRI protocol, issues will arise, and it's important that they can be easily recognized and, when possible, corrected for prior to any clinical interpretation. Dynamic susceptibility contrast imaging exploits the susceptibility-induced changes in T2 star due to contrast agent as it passes through tissue. What you will see here is the DSC acquisition over time and the corresponding signal profile. Following contrast agent administration, we can visualize this change in susceptibility with the transient darkening of the blood vessel and the rapid decrease in the DSC signal profile. This signal drop, along with the signal baseline and recovery, are the three main components to scrutinize when evaluating the DSC signal profile. To begin with, the baseline signal should ideally include a minimum of 30 to 40 time points and is based on Dr. Boxerman's publication, which showed that 34% more noise was present when DSC was collected with just 10 compared to 50 baseline time points. Based on this, the contrast agent injection is typically given at approximately 60 seconds into the DSC acquisition. Furthermore, since relative cerebral blood volume is calculated through the integration of the delta R2 star, there needs to be a sufficient post-bolus signal drop and signal recovery to calculate an area under the delta R2 star curve. Seen here are the results of a proper DSC acquisition, which includes the post-processed relative cerebral blood volume and flow maps, and the DSC signal profile. We can appreciate the tight post-bolus signal drop most evident in artery, seen here in red, and can also be seen to varying degrees in the normal appearing white matter, seen in blue, the contrast enhanced lesion, the T1 contrast enhanced lesion seen in green, and throughout the whole brain, which is seen in black here. I would also like to point out that the transient noise seen in this darkly shaded region is often present at the beginning of most DSC acquisitions, so the first 5 time points are routinely discarded. And seen here is another example of a properly acquired perfusion image with the corresponding DSC signal profiles in different tissues. Again, there's a sufficient number of baseline time points, a tight post-bolus signal drop, and an adequate signal recovery. Both gradient echo and spin echo acquisitions can be used for calculation of perfusion maps. The difference being that visually, while spin echo images are primarily sensitive to microvessels, as you can see here, Both methods retain some sensitivity to the larger diameter vessels, but with gradient echo showing a greater sensitivity to the larger diameter vessels. One caveat being that spin echo acquisitions produce weaker post-bolus signal drops and therefore have a lower signal to noise ratio. The signal to noise ratio is commonly used to characterize the quality of the DSC signal quantitatively. And it's simply the mean of this signal divided by the standard deviation. Another way to quantitatively characterize the DSC signal quality is by using the contrast to noise ratio, which incorporates both this baseline signal and the delta R2 star post-bolus signal profile. Simply, the contrast to noise ratio is calculated as the maximum value divided by the standard deviation of the baseline signal. In a recent report by Dr. DeJerns, it was reported that for both gradient echo and spin echo data sets, voxels with a contrast to noise ratio below 4 produce highly unreliable results. You can see here histograms from the gradient echo and spin echo data sets. 4 is kind of around here and here. And you can see the typical fraction of voxels within the data set. That would be below or above 4. Here you can see the delta R2 star signal profile for CNR ranging from 2, which looks very poor, and you can not really distinguish any discernible delta R2 star signal profile shape, to 5 and 50. So at 5, you're seeing more clearly the discernible shape that we're looking for. In the figures to the right, this is the mean and the standard deviation of RCBV values compared to CNR ranges. You can also see right around 4, there's much greater standard deviation, and the higher the CNR, the lower the standard deviation RCBV for both gradient and spin echo. And so circling back to our previous examples of proper DSC acquisitions, all of them clearly have adequate SNR, and CNR where 84% of the voxels at least had good signal quality. Now that we know what good quality perfusion data should look like, we can begin to identify DSC data that doesn't really meet our expectations. In the majority of cases, issues with DSC acquisition and post-processing relate to timing and presence of contrast agent administration, the rate of contrast agent administration, DSC signal noise, and susceptibility artifact. These 4 issues are what I will be focusing on, and most of the examples I will be presenting can be found in our recent publication. The next few examples all showcase the importance of contrast agent. While not necessary for a low flip angle acquisition, a preload dose of contrast agent is required for a moderate and high flip angle approach. The preload should be given approximately 5 to 6 minutes before the DSC acquisition sequence begins. And without a preload dose of contrast agent, the DSC signal can overshoot the baseline, as seen here, and can cause an underestimation of RCBV, which is easily seen in this resulting perfusion map. The images from this bottom row were collected from this exact same patient during the same scanning session, but with a preload present. So you can see the clear difference in signal or in image quality and accuracy. In the example shown here, the contrast agent was not given during the DSC acquisition. Aside from the somewhat oscillating noise, the DSC signal is relatively flat. You can see that in the other tissue types as well. In addition, the RCBV is mostly speckled or spotty in appearance, and the CBF has a relatively flat appearance. And this data is uninterpretable. And while the noise in the artery for this case looks like it could be a signal drop due to contrast agent, it is actually noise. And if you compare it to the signal in the other tissues, you can see that there's no corresponding signal drop, confirming that no contrast agent was administered. Again, the perfusion maps don't look good, and the DSC images show no darkening, which would be present if contrast agent was injected. Aside from the lower contrast agent dose, using a low flip angle protocol has an additional advantage that if something does go wrong with the timing of the contrast agent, for example, if it was given too early or outside of the window of DSC acquisition, a moderate flip angle acquisition can still be collected, essentially giving you a second chance to collect data. And you can see here, we were able to do that. In this example, the protocol was followed and the contrast agent was administered at the correct time at 60 seconds into the acquisition. However, there was a leak in the IV and no actual contrast agent went into the patient. So that's one thing to think about when you do everything correct and you don't see any signal change. Similarly, for this patient, the IV line was inadvertently clamped. And despite this, some contrast agents still entered the patient. And while the maps don't look quite as bad as the previous examples, this data is still not trustworthy and it shouldn't be interpreted. For this case, while the contrast agent appeared to be correctly administered, the DSC profile is much too shallow to allow a meaningful calculation of the perfusion maps. The arterial signal drop might look somewhat deep. However, the drop seen in other tissues is essentially flat, as you can see here. Again, this is confirmed by the poor appearance of the perfusion maps. You can see the speckly appearance. And again, another example of shallow post-bolus signal change here. These shallow changes are typically seen with patients that have poor vasculature, including those with chronic drug abuse, Ehlers-Danlos syndrome, peripheral vasculopathy. One way to prevent this is by reducing the contrast agent injection rate from 5 to 3 milliliters per second in a patient with previous history, maybe noted in the chart, or if you've had a previous experience where the RCBV does not look good, then it might be best to reduce that rate. The RCBV maps are seen here for all the previous examples of missing or shallow contrast agent. For the most part, they can be easily identified as poor data just based on their spotty and speckled appearance. The no preload dose had signal voids, and potentially some images might sneak through and look somewhat okay. However, the contrast to noise ratio is also very low for all data sets, regardless of the reasoning of the contrast agent being shallow or absent. And if you recall, for correctly acquired DSC, all the acquisitions had at least 84% of the voxels contained good CNR. Now, these are the CBF images, the blood flow images. And while they're slightly more difficult to recognize, one telltale sign can be a relatively flat or spotty appearance. However, this is not always the case, and further scrutiny of the DSC signal profile is required. The next few examples will all showcase the importance of contrast agent injection rate. Inconsistent and slow or delayed rate of contrast agent administration can also lead to inaccurate data. For this case, which is suboptimal, the DSC acquisition has substantial signal recovery and is therefore still suitable for RCBV calculation as it's dependent on the area under the curve. This may not be the case for CBF, which is more sensitive to the bolus delay and dispersion. The case seen here is not acceptable for perfusion calculation, as the slow rate of injection also impedes the ability of capturing any significant return towards baseline. You can see it's pretty much relatively flat at that peak. While delayed or wide post-bolus signal profiles can occur due to contrast agent injection issues, they can also occur when the saline flush is not administered at the correct rate or immediately following the contrast agent injection. It's also been observed when the contrast agent and saline were inadvertently swapped, and might even occur just based on different patient physiology and heart function. Here's an example of an irregular contrast agent injection, which is typically seen with manual contrast agent injection, or if the power injector sticks, despite being suboptimal, adequate RCBV might still be determined since the calculation depends on the area under the curve. However, you should use caution since the signal irregularity might be caused due to motion, which should not be integrated as it's not representative of the true signal changes. In this case, motion correction did not considerably alter the signal, and the resulting perfusion maps further confirm that these were true signal changes. So as we can see here, with inconsistent, delayed, or irregular contrast agent injections, the image quality can vary quite a bit based on the shape of the DSC signal profiles. So you can see here 17 to 78% of voxels had good quality in these three images. But this is also reflected in the visual aspect of the RCBV. You can tell these two were the poor quality images, and this one was not. The next few examples I'll showcase when an undesirable amount of noise is present in DSC signal. The data seen here was collected shortly after a patient experienced a seizure, which resulted in quite a noisy DSC signal profile, with signal voids seen in the resulting perfusion maps. However, this type of issue can be easily corrected for by application of motion correction using image volume co-registration or noise filtering. Also, sometimes relatively large noise spikes, seen here, might be present in the DSC profile. These individual volumes can be removed as long as they don't alter the underlying DSC signal profile shape. For this particular case, while the images in the top row are suboptimal, they are still interpretable and would have resulted in a similar RCBV assessment as those in this bottom row at following motion or following removal. And you can see here these were removed simply by altering the included baseline signal and discarding all these time points, and then removing the volume which the noise was present in. While not as common, a regional DSC baseline shift might also be present. By adjusting the baseline time points, as you can see the shift here, used for the calculation of the perfusion maps, the transient regional shift can be removed, it's discarded, and interpretable perfusion maps can be produced. And just as a note, this issue is most likely caused due to a failed coil element. For this case, poor quality data resulted because the in-plane phase encode direction was incorrectly set to right-left, which resulted in severe ghosting in the phase encode direction. You can see this here on these DSC images, the ghosting on the sides especially, and this made the DSC signal uninterpretable. Noise may be intrinsic. It could be present as an early transient due to patient motion, and especially following long scans or a seizure. It can also result from patient anxiety, or could be due to the scanner hardware, coil, or scan settings. Noise is most often seen as signal voids present in the perfusion maps. However, in most cases, motion correction or smoothing filters can easily be implemented to improve the contrast to noise ratio and resulting accuracy of the perfusion maps. And you can see here that motion correction dramatically improved the percent of good quality voxels from a range of 41 to 87% to a range of 72 to 93% of voxels. The last couple examples will all showcase susceptibility artifacts. Since DSC exploits transient contrast agent-induced changes in susceptibility between the vessel and tissue, anything that affects susceptibility might also impact these measurements. Unwanted magnetic susceptibility effects might result in signal loss and distortion and can be observed in patients with, for example, implanted screws, surgical clips, blood products, and shunts, in addition to dental work and hair extensions. In this particular example, the patient's braces made their images completely uninterpretable, and you can see this throughout the entire brain. Susceptibility effects can also be present towards the skull base, near the bone-air tissue interface, as seen here, or near resection cavities or sinuses. These distortions are lessened with spin echo, but at the cost of lower signal to noise. However, it's also important to ensure that when these distortions are present, voxels with faulty DSC signal are not included in the brain mask so that poor quality data is not interpreted clinically. You can see here all the voxels with a signal to noise ratio less than 10 would be best to not be included in your final maps. While different masking techniques offer various advantage, noise-based techniques can provide a better gauge of signal quality than Atlas. And while Atlas tend to be more appealing, the noise-based tend to be more accurate. In this particular example, approximately 50% of the voxels on this slice that were within T1 enhancement had poor quality contrast to noise ratio. So it's important to not include faulty voxels. So while the DSC imaging is relatively straightforward to obtain, it's still possible to collect poor quality data. With that said, it's important to prevent issues from arising by being prepared. The MR scanners should review the DSC acquisition protocol and contrast timing, visually verify that all the tubing connections are in place and not clamped, set an appropriate flow rate. Additionally, patient education concerning the scanning process and effects of movements during acquisition has been shown to reduce both patient anxiety and motion during the scanning session. There was a report by Ali that was very informative on that. And with every great intention, issues will arise, and it's important that we can recognize poor quality data so that uninterpretable data is not used for clinical decision making and suboptimal data is not overly relied upon. It's also important to identify the sources of errors so that the same issue isn't revisited. And lastly, to apply corrections to the data during post-processing to improve accuracy. And since this is an IB users meeting, I'd like to point out that there are built-in warnings in IB to alert you to miscontrast agent, and also the ability to perform motion correction and adjust the baseline and the limits of integration as necessary. As you can see here, you simply dragging this bar over, and then you can alter also the limits of integration as well. And you can see them updating here. I would also like to conclude by emphasizing that while there are several issues that can result in DSC perfusion being suboptimal or uninterpretable, DSC perfusion is quite robust, where most of the issues that are encountered are largely due to contrast agent administration or patient motion. And also remember, following the consensus protocol recommendation will result in better quality data. And lastly, the majority of data presented here can be found in our recent publication in Frontiers in Radiology. I would like to acknowledge the members of our team and also thank you for your attention. Are there any questions?
Thank you, Melissa. We'll open it up. If anybody has questions, if you could please type them in the Q&A. And Melissa, while we wait, I do have a question for you. Are there any issues that you encounter most frequently?
I think the most frequently encountered issue is probably noise, which can be corrected for, but outside of that, related to human error, would most likely be contrast agent administration issues. So it's very important to review the protocol and ensure that everything is in place, the tubing isn't clamped or kinked or any other issues related to that.
Fantastic. I wanted to add also that Imaging Biometrics has a protocol. If anybody listening needs access to that protocol and wants to send us a message or even type it in the Q&A, we can make sure that you have that protocol in place as well.
Hey, Melissa, this is Mike. I submitted a question to the Q&A, but it may not be the right place, so I'm just going to ask it verbally. How much of a benefit does the low flip angle approach, which of course eliminates the preload dose of contrast, how much of a benefit does that offer in terms of simplifying or streamlining the data acquisition?
By using the low flip angle approach, you don't have to give the preload, obviously, and just the one injection. I think the biggest benefit is the patient doesn't have to have as much contrast agent. You don't have to wait the 5 to 6 minutes for it to the preload to circulate. And again, the advantage of if something does go wrong, you could always collect another mid flip angle acquisition.
Okay, I don't see any additional questions, so I think this concludes our webinar for today. This recording will be made available for future viewing, and we want to thank you, Melissa, for the presentation today. And if anybody has additional questions, you can email us as well. So again, thank you and have a great day.
Thank you.